Hello everyone, welcome to Hot Seat. I'm Omid Moghaddas from Iran and I'm so excited to be your host again during these online educational webinars. And again, I'm so excited to have a dear friend of mine from United States, Michel Azer, is here with us today. And I'm pretty sure that today's topic is one of the most demanded topics in the field of implant dentistry because today he will talk about complications in aesthetic implant dentistry. And me, myself, I'm very excited for that. So hello, Michel. Welcome to
Hey, how are you?
We're very excited to have you with us.
Oh, yes. Thank you for the invitation.
Pleasure.
I'm
pretty
the
sure,
lineup. Yeah.
I'm pretty sure most of the people around the world know you and your beautiful work. And for those of you
Thank you so much.
that may be not very included in your works, I really recommend you all to go to his Instagram page and Facebook page, and then you will understand the real art. So as a tradition, I will have a brief introduction and CV of Michel. Michel Azer brings with him many years of experience in implant dentistry. He completed his specialty training at the prestigious Boston University in periodontology and advanced dental implant surgery. Following his training, he remained in academic position and was clinical assistant professor for the postdoctoral periodontal program. And then he moved to Houston, Texas, and now currently he's assistant professor at the University of Texas, Houston. Apart from his outstanding clinical skills, Dr. Azer also lectures nationally and internationally with a focus on aesthetic dentistry. His research projects have earned him much deserved recognition, and one of his projects was selected among 4 finalists nationwide for the prestigious Ballant Orban Award. It's my honor, my privilege, and I'm so happy to welcome you again and Hot Seat. And the topic today is going to be complications in aesthetic implant dentistry. We are ready for your amazing presentation, and at the end, we will have a fun discussion on the topic.
Yeah. Thank you. All right. So first of all, I want to acknowledge you, Omid, for all your work and all the work that you've put to educate the people around you. I told you this a long time before. You're really one of the few people who care about educating the others. You bring all the expertise from around the world and bring it back to your country. And that's a huge work on your shoulders for sure. So I'm happy I'm going to be talking today about complications in implant dentistry. This is one of my most favorite topic to talk about, primarily because I had these complications firsthand. I would like to share my pure experiences with complications and mistakes that I've done before, and also ways to prevent them from happening and ways to fix it. Omid, can you see my presentation now?
Yes, perfect.
Perfect. So let's take a look at a very basic picture here. When we look at this picture, it's always attractive to our eyes, the harmony in it. It's a nice smile, of course. And why we see it beautiful is that there is some sort of harmony between the pink tissue and the white aesthetics. This picture was shared to me by a friend of mine, Ricardo Kern, in Brazil. And when I looked at this picture, I told him, you know what? I never took a nice smile in my clinic, probably because I see the patients after they undergo a lot of procedures, but there's nothing really as beautiful as natural teeth. So to kind of put the standards to everyone in the audience, I want to make sure that we're all on the same page before we start our topic. I'm a periodontist by training, so pink aesthetics is my main concern in my own clinic. Doctors refer these cases to me to give them nice tissue in the end to work with, especially when patients have a high smile line. So the things that I got judged for by other clinicians and by patients are these. The first thing that I look for is the gingival margin and how symmetrical it is between the two centrals and two lateral incisors. The second thing I look for is the zenith, which is the maximum height of contour at each tooth. There are specific studies that was conducted before, and it tends to be the zenith, which is the highest point at every tooth, is less and less as we go to the canines. It's more distal at the centrals, and then it goes more mesial at the canine. And also I look for the zenith triangle, which means that the laterals are usually a little bit shorter in height compared to the canine and the central incisors. We also look for papillary fill, that there's no black triangle, and this is a very hot topic that we're going to discuss today. We look at the texture of the tissues around the implants or teeth, and we also look for color and lack of inflammation. So this is very important in my practice, and I hope it's important in your practice as well. Let me tell you how important that kind of tissue is. In 2005, we came up with a pink aesthetic score. So that aesthetic score, basically, we mastered all the success criteria for implants. Implants are now osseointegrating, but now we took it another step forward, and we're now trying to master also the aesthetics around the implants and the pink tissue around the implants. I look for the papillary fill, also the buccal margin, and how the contour around the implant will be, also the texture and color around these implants. So we as dentists have also elevated the bar very high for ourselves, and not to mention patients, because patients are expecting to come to our clinic with a smile like this and come out as supermodels in your clinic. And that's because they look at magazines everywhere and everyone is marketing their dental implants. And of course, this is also putting pressure on our side to be able to match their expectations. So let me share with you a very humbling experience here, which will set the tone for the rest of the presentation. This was a patient that I saw in my residency. Of course, I was very excited to see this patient for the first time, an aesthetic case. We take pride in these cases. You don't take these cases unless you're qualified or competent enough to finalize the result. So this patient had a failing bridge, as we can see here, with 3 abutments and 1 pontic in the central incisor, and this bridge has broken. So after caries control, and we saw that the lateral incisor as well is not going to be restorable. So the plan is to take out this tooth, the lateral incisor, and restore the missing central and lateral incisor with implants. It sounds easy. So we go ahead, we make a wax up and fabricate a temporary bridge. And then we go ahead with atraumatic extraction. There was enough buccal bone. We go ahead with a simple socket preservation procedure. We then go ahead and harvest a connective tissue graft and close the site with a socket seal kind of procedure. And this is how the case was closed, and now the healing is very, very predictable in that case. Now, as for the central incisor, because the patient lost a lot of bone over the years, we had to stage our case. So we wanted to do a bone augmentation first with a collagen membrane, and then place the implant in the second stage. So this is my approach back here. Again, I changed a lot of my techniques. I would not do the same incision design again. But again, this was the residency. This is the time to learn. And I'm just sharing my pure experience with you. So we do a full thickness flap elevation. We stabilize the membrane with 2 tacks in the apical. And this is how I still do it nowadays. We pack our bone graft, and we use a periosteal suture to stabilize the membrane. Just to clarify how the suturing goes here, after we split our flap on the top, we're gonna hold with a suture coming from the palate, the periosteum, and this tends to stabilize things into place, and then you're free to suture your flap over it on top of it. So I'm going to fast forward this case and just show you the final result where will be. So we placed the implants, we removed the tacks, no flaps at all. We did a small soft tissue augmentation at the papilla area because it was deficient. And this is how the case was finalized. Now it's ready to be uncovered. So honestly, with the exception for the scars that formed from the vertical incisions, I was very happy with that result. I gave the restoring dentist a lot of tissue to work with, and now it's his job to shape that tissue. I also take responsibility for all these cases. I'm not blaming anyone. It's just like a matter of communication with other dentists. So if you're practicing at your own practice and doing everything, that's of course a lot of stress, but you have more control. If you're a specialist like my case, then I need to communicate well with the restoring dentist. So patient called me and told me I'm not happy, and this is what I'm presenting with. So for me, it was a shock moment to see that patient going from where we are to here. And I kind of asked myself very, very specific questions. What may happen wrong? Did I do something wrong? Did the patient do something wrong? And this is really the cases that is humbling to us in our own clinic. Thankfully, these cases, we don't see it as frequent now because of the high quality education that's available over the world. And also, as we get experience and seasoned as clinicians, we don't see these cases or complications anymore. But I want to also point that this is the problem that we're gonna be facing today, or we're talking about today. And it's not a small problem. It's a very big problem that we're talking about. So at this point, you're either honest with yourself and you ask yourself, what did I do wrong? Or you start to point fingers and blame everyone else. And I hope we're all honest to face our own problems and learn from them. So to look back, the picture here on the right side of the screen, it shows where the tissue was before the uncovery procedure. And on the left side, it shows how it looks like after the uncovery and loading the implant. Of course, the central incisor took a major hit with how the tissue looks like right now. So if I want to compare how much loss happened over this time, which was a period of only like 3 months or 2 months, that's a huge loss and a huge loss of contour. So the purpose of this series of this or this presentation is to share my experience on how I learned to prevent these problems from happening, and also how to come back in our own practices and be able to reverse it in some cases, with a lot, of course, of humbling experiences that came in the way. So patients come to our own clinics with a smile like this or teeth that look like this, and they expect to go out with this kind of result, okay? And that's because, like we mentioned before, marketing strategies and everything that puts pressure on us as dentists. I tend to simplify things the way I look at it and explain to the patient. We have 2 phases that we have to go to if implants are your option or your choice. We have to go through a surgical phase, and it has its own preparations, and we have to go through a prosthetic phase. So as we break things down, I like to break things down as diagnostic phase and pre-implant preparation that includes grafting, consultation with the patient, also gathering all the CT scan and setting the right treatment plan. First stage of implant placement, second stage and temporization, and finally we get to the final crown. So with this in mind, if you notice that, Omid, when you do immediate implants, you're more likely to get nice results than cases that you have to do bigger augmentations to it. And I have a theory in that, you may agree with me, that it all depends on cutting down the number of procedures that you do in your clinic. So the more that you do in one time, the better the outcome will be. So let me give you an example here. It's the oldest trick in the book. We go ahead, this is a patient who had a failing central incisor. We do an extraction atraumatically, we maintain the buccal bone, we place our implant in the right prosthetic position, which is slightly palatal to give buccal gap so we can graft it with bone. And then we take an index with an open tray impression coping. That now index will give me some time to work on the temporary until the implant osseointegrates. And that's the basically a simple example of transitioning between one step to another. So when the patient come back, we just need a very small tissue manipulation phase, and we have almost a perfect temporary shape to place and very minimal chair side at the same time. So we're cutting a lot of steps by doing this small trick. We're basically putting all these steps up to the temporization until the tissue is contoured, and then we're ready for the final prosthetic delivery. Now, in a case like this, it's very predictable because we have all the criteria that fits the immediate implant. However, what do we have to look for when we're placing these immediate implants? Or in other words, can we do this protocol for every patient? So this is my criteria to kind of jump into immediate implants in my practice. So we want to have good buccal bone. I prefer 2 millimeters of buccal bone, which is very rare to find. But if you see 2 millimeters of buccal bone, you're more than safe to place the implant immediately with very minimal problems. There's no periodontal involvement, there's no soft tissue defect or trauma, and you have enough sufficient implant stability that's more than 45 or equivalent to 45 Newton centimeters. Then you can load the case even immediately at the same time without any problems. However, we have cases where we already have missing teeth or areas that has periodontal pockets or periodontitis. And these cases will require much more attention because we do not know how to place the implant and do everything at the same time. It's going to be very tricky. So let's go back to our first step here. And from now on, I'm not going to be discussing about the immediate implants. It's basically, we're going to go step by step on more complicated cases. So let me give you this case, for example. First of all, let me talk about diagnosis and pre-implant preparation, okay? So there are two things that I look for in that phase. And the goal from this phase is to basically communicate with the patient if there's any recession that may happen or any black triangles that may happen. We use the CT scan, probing, everything that we need to do to collect certain numbers and translate that to the patient. And also in the preparation phase, which is maybe the socket grafting or bone grafting phase, I want to minimize the tissue distortion to make it as natural as possible. So we know from classical studies by Tarnow and Salama that things get complicated when you go from treating teeth and up to increasing the number of implants that you do. So the papillary fill, for example, in between teeth is much easier to achieve than compared to two implants adjacent to each other. Now, I don't take these numbers as a fact. It's only a guideline for me that it's only getting challenging for me as we increase the number of adjacent implants. So it's a direct correlation with complexity in my clinic. So the two things I really look for here is presence of buccal bone and the presence or the height of the interproximal bone. I know that previous speakers that came on your webinar, a series of webinars, spoke about this. You have Musa, Howie, they're all great speakers. I learned from them. But I'm going to just touch base on that and update the audience on what we know now about these two things, which is very important for the final aesthetic outcome. So the buccal bone crest, this is a topic that was studied by Boozer's team. And what Boozer showed that if you have buccal bone that's 2 millimeter, you're not going to get resorption. And that's because there's a lot of blood supply coming from within the buccal bone that will maintain the buccal crest. But let's ask ourselves a question. How many times do we have a patient with 2 millimeters or more of buccal bone? And the study has been made and it's almost 2% of the times only. So that leaves us with 98% of the times we're facing the challenge of loss of buccal bone. And what this says is that you're also facing the challenge of having buccal recession, for example. And how about the interproximal bone? We know Salama and Tarnow's studies back then. We had a small update in 2003, a study by Joseph Kahn, and it showed basically that what determines the height of the adjacent bone of the papillary fill is the height of the adjacent bone on the interproximal teeth. And that basically makes sense. So if you have two adjacent implants, there is no tooth or periodontal ligament structure to hold the bone high. So it's basically relying on the peak of bone holding itself. And that's why partial extraction therapies come into play, where you can play around this part and trick the body. But this is not my topic for today. I'm just going to address our traditional way of doing implants. So Joseph Kahn and his study showed that it's the interproximal bone that determines the height or interproximal papillary fill. And also, whenever I have a high lip line or an aesthetic case, I would love to do a mock-up for the patient just to highlight the fact that we may end up with black triangles, and the patient has to expect that beforehand, and also the need to do soft tissue augmentation to counter the bone loss or the tissue loss or deficiency on the buccal side. So it's good in all ways for the patient to kind of know the result beforehand, and it reduces the amount of stress in our clinic if the patient knows that beforehand. Now, let's go and see what we want to have in our first stage of implant placement. There are very important things that we want to achieve from that step. We want to make sure that first, the implant is placed in a restoratively driven position. The second thing, I want to at least have 1.5 millimeters of buccal bone protecting the implant all around. 2 millimeters would be great. More than that is fine, but at least 1.5 millimeters of buccal bone. And then we want to also graft if there's any fenestrations or dehiscence around the implant. But the secondary goal, which addresses the transition between this step and the following step, is also very important. And I want to facilitate, by all means, how we do the uncovery stage or the temporization phase. And also, if possible, we want to have a screw retained restoration. Is better for the cleansability and retrieval of the crown if something happened in the future. I also want to add that I had a big change in mentality between the phase where I had the residency and how I practice things now. I don't aim for the ideal 3D restorative position, but the adjusted position. That means I was happy to place the implant in the restoratively driven position that will give me a screw retained restoration, but I had to do big augmentations to do that. And I was enjoying it back then. But now, as I mature and my understanding of implantology increase, I want to have the adjusted position, which means that I want to place the implant in the position that will minimize big bone grafts and also have it as a screw retained restoration. We have three options to achieve a screw retained restoration by manipulating the position of the implant and follow what the patient have. we have co-axis, screw axis, multi-unit abutments, angulated screw channels, and our last option is to do a cement retained restoration. Again, it's up to you, to the clinician. I don't recommend one over the other, but this is the way I see things now as my understanding matures. So let me walk you through a case in full, step by step, from the diagnostic part up to the final restoration. Here's a patient who had problems with her front teeth. The lateral incisor, the right lateral incisor, the crown was falling a lot, and the left one had a big periodontal pocket. That's about 9 millimeter periodontal pocket. The x-ray shows a vertical bone loss. So as part of our diagnostic phase, we want to collect these numbers and also detect where the bone is, okay? Because the periodontal pocket also has a shape, and we may utilize the shape of the periodontal pocket to kind of manipulate the tissue or trick the body to form bone in the right position. So we examined the CT scan, and it shows that there was a vertical fracture in that lateral incisor. There was plenty of bone loss that was reaching all the way to the canine, and complete blowout of the buccal bone on the lateral incisor. So what we wanted to do is, of course, explain to the patient, but in my head as the surgeon, I draw a mental picture of what the bone looks like under the gum. And it's very important because whenever I'm doing an incision design, I want to place the incisions or do my surgical manipulation in a way to optimize the healing outcome. So my goal from this procedure, or from the end result, is to grow back the bone. So the first goal will be guided bone regeneration to regenerate the loss of buccal bone or buccal dimension. And the second goal would be guided tissue regeneration. For those of you who don't practice periodontology on a daily basis, GTR is basically growing cementum, periodontal ligament, and bone around teeth that has been lost. And we can see here from the CT scan and the probing that there was loss all the way to the canine as well. So with that in mind, we want to plan our surgery. Now, for the other lateral incisor, it was a core buildup and it was getting weak, so there was not really a furrow effect. So what we wanted to do here, because it's one of the rare occasions where you can do immediate implant, you have sufficient buccal bone on the buccal side, very thick one, no periodontal pockets, good sufficient apical bone to get implant stability. Now we want to do an immediate implant in that site. So here's the plan. The plan is to place an immediate on the right side and do a stage approach on the left side. So we go ahead, treat the left side first, so we give it enough time for healing. We do an extraction, and we can see the vertical fracture on the tooth. We then go ahead and manipulate the tissue. So here we do a tunneling procedure, which is a full thickness tunnel procedure. In that kind of approach, we're basically elevating or separating the soft tissue from the underlying bone. Now, bear in mind, I knew beforehand what the shape of bone looks like, so I can, with my instrument, manipulate the periosteum underneath to separate it from the bone. And then we place a collagen membrane on top, and this is how the case basically ends up. So buccal bone that was deficient, now we're trying to overbuild to the buccal side, because this is a lateral incisor, and lateral incisors are small in diameter. And what we know about bone grafts is that they tend to shrink over time. It's part of their remodeling process. So always aim with this approach to over-augment on the buccal side to compensate for the shrinkage that will happen. Now we go ahead, and this is where our transitioning part, which I want to highlight in today's presentation. We want to close every case like that with a pontic. And the pontic serves many purposes. First of all, maintain the tissue architecture, support the papilla, and also provide a semi-healing environment for the bone graft. So there's less chances that you get food stuck in there or debris stuck into the bone graft and that may cause an infection. So with that in mind, we went ahead. Now we're done with the pre-implant preparation part and transitioned it very well with our Pontic to the second stage, or the first implant stage. We go ahead and approach this case. Here's how the first month of healing looks like after taking out the tooth. Here's how it looks like at 6 months. And we go ahead and examine our CT scan. So it looks like after 6 months of healing that we were able to maintain or create buccal bone that's sufficient to protect the implant in our implant placement phase. And on the immediate implant, like we discussed before, this is a perfect site to place an immediate implant. So we went ahead. The implant placement, there are some criteria that we will discuss on the ideal implant or the desirable implant placement. In this case, we chose Nobel as the implant of choice. It's a conical connection. I usually like conical connection implants with flapless procedures because it makes it easier for us to connect and disconnect parts without pinching the tissues around it or getting lack of complete seat of the abutments. So this was the plan. This procedure was done in a guided fashion. We went ahead and extracted the tooth, the lateral incisor. Then we make sure there is enough buccal bone present. We then seat our guide and also start the drilling process and place the implant. In that case, we didn't get enough implant stability. And on the left side, we already have the tissue prepared perfectly. I want to avoid flaps on the left side. And so we do a small tissue punch and place the implant in a flapless fashion. So as you can see, Omid, everything is well calculated beforehand with our guide and CT scan. So on the buccal side, I'll see that, or we anticipate some lack of buccal bone on the left side. So we want to also augment this and protect the implant threads from future exposure. So that's why if I'm planning to do flapless approaches, then I have plan A, plan B, plan C. So I prevent any surprises during my procedure. So we had this in mind beforehand. This is how the case looks like after placing the two implants and buccal and placing the bone graft. We then, to do our augmentation, we went from the vestibule just with a vista approach, kind of incision, full thickness flap, and then prepare our bed. We want to make sure that there's no tissue that's embedded. We use a high magnification for that procedure. I use loops that is 3.5 magnification power. And then we place our bone graft to protect the threads of the implants that was placed. In that case, there was no threads that was exposed. And this is how the case is sutured. Very simple procedure. Chromic gut is more than enough. We have the periosteum to protect the implant, and also the patient will appreciate that there's not a lot of swelling that will happen when they go back. So this is what we're left with here after the procedure was done. Like I told you, the immediate implant didn't get a lot of stability. It's kind of a problem when you do guided surgeries. You don't get a tactile sensation of what the bone looks like. And we're left basically with a 20 Newton centimeter torque. So in that case, I wasn't comfortable to load that implant. So the plan was to, again, temporize it in the same fashion using Pontic that's completely fixed. So here's the case. We use the Pontic. We glue it with composite on the back. And this is how it looks like at the time of surgery. And this is how it looks like after the osseointegration phase. We usually wait around 2.5 months before we start loading the implant. So you can see here that the tissue is already shaped in its final shape. So for me, I'm not scared because we always hear that tissue punch is bad, you're losing tissue, but here you're not losing really any tissue because you're cutting away from inside and there's no need to really manipulate the tissue a lot. And that's the power of understanding the transition points when you do this kind of procedures. So a simple tissue punch, connect the implant abutment. As I told you before, conical connection was chosen here, so it was really easy to place the abutment all the way to the implant, and we confirmed that as well with x-rays. But this is kind of an example of if you use a traditional, like an internal hex or any kind of connection, trilobes, or versus using any conical connection, you will see the power of conical connection that even if you have tissue that's trapped on top, that the abutment, as it goes in, it will push the tissue to the side and prevent any trapping of the tissue. So this is how the case looks like after the temporization phase. We can, the patient wanted to proceed with the 2 central incisors as well as veneer and crown. And this is how we can finalize everything at once. It's much easier for the lab to finish the case. We can also use and the angulated screw channel abutment to get full access to the screw. And this is how the first try-in from the lab came in. We had few adjustments to do primarily under the gingiva, where it was too thick to place all that material under the gingiva. And this is what we're looking at now at the time of delivery. So it's very predictable if you're following the criteria or following certain principles of implantology. This is how the seating was, and this is the final outcome at the time of delivery. You can tell that all our work paid off by minimizing the incisions and also working on transitioning between one step to another. And this is how it looks like at the 2-year follow-up after the delivery. So I wish that every case goes like that, but this is not the case. We know that implantology can have much tricky cases than what I'm showing in that case. But this is only to set the tone. The problem with implantology is that every step that we discuss had a lot of potential problems that may happen. And these are some of the problems that may happen, at least in my hands, or I've experienced before. So you can tell I've made almost every mistake in the book to start with. And that's why I learned. There's no way around that. You have to go through the learning curve. So I'm gonna be discussing these 4 cases. And these 4 cases also present the complexity of the problems that I encountered during the treatment. So these are problems that happen. I made the problems, and I'm going to share why I did it, but I also want to share how to fix it. So let's start with the first case here, first complication case. This was a lovely patient who I saw in the office. She had veneers all around her mouth, so very high expectations as well aesthetically. And what she heard when she was biting on a piece of cracker, she heard the sound, and she came to us, and we took a CT scan, and it revealed that there was a horizontal fracture around the lateral incisor, the right lateral incisor. So our treatment of choice was to replace that tooth with an implant. So we took the tooth out. It was already fractured. So I tried to preserve the current veneer just for the temporary phase. And I used gauze. This is a very common trick we can use to prevent scratches on the crown. And then we go ahead, we place the implant like we normally do. We place it in the most ideal, palatally positioned a little bit to allow for a screw retained restoration. And we, again, graft the gap with our FDBA. That's what I use commonly, or 95% of the time. So you can see that I had a lot of bone on the buccal side. I was wishing that this buccal bone to hold itself. Now, when I recall the CT scan, the buccal bone was very thin, and it's very expected that after the osseointegration phase, we got this kind of problem. So even though it's a small problem, but again, it's a very predictable kind of defect that may happen after immediate implants. So the way I look at it, if you can predict or expect this kind of healing, then it's no longer a problem because you know how to fix it as well. So looking at this phase here, we went ahead. This is how the initial situation looks like. The pressure here from the pontic that we delivered to the patient only maintained the tissue shape, but it's not connected all the way to the implant. So with that in mind, this is how it looks like from the oblique view. So we did, again, the same principles, conical connection, it's powerful. We split at the crest just to allow for the tissue separation in a partial thickness fashion. We connect our abutment all the way to the implant, take an X-ray to confirm seating, and it was time to fabricate a temporary crown. So there is a very important principle that I follow if I'm planning to do a soft tissue augmentation. I never put the contours of the crown of the subcritical part to its full extent or full contour. I usually like it to be as thin as possible, okay? So here's the rationale, and I hope this diagram can help us. Now, if we compare the yellow abutment to the purple abutment, okay? I want my abutments to be as narrow as possible to give enough biologic space for the tissue to grow. It's very important to understand the healing of soft tissue. When you do a soft tissue graft, it will have some swelling in the first days, and then it shrinks back to its final position. The more room you give for the tissue to grow, the bigger it's gonna look at its final maturation, okay? The less compressed, the more it can grow. So that's why I always aim for a narrow emergence profile, primarily in the first few weeks of healing. And then also, I want to have an undercorrected CAJ. That means I'm not putting the CAJ in the final position yet. I undercorrect it just to make sure that if there's a chance for the tissue to grow, it grows all the way and then it will shrink back. And that would be then my final CAJ position. So we go ahead. I have the assistant work on the temporary crown to finalize it and shape it and finish it, while I do split thickness bed preparation or tunnel preparation. We went ahead and split all the way on the buccal side, and it was time to harvest the soft tissue for our graft. So my favorite area to harvest soft tissue is this layer here, okay? This is very easily achievable if you harvest a normal free gingival graft and remove the top epithelium, all right? The deeper layer is not very desirable because it's full of glandular layer, full of fat, and then that fat will tend to resorb. So you lose the volume that you gained. While in this connective tissue that is right below the epithelium, it has a high collagen content, and it tends to not only stay in place, but also to grow. So this is how it looks like after harvesting from the palate, very small tissue graft as a free gingival graft, and then remove the epithelium. We then fit it, pre-fit it. Also, the advantage of having this dense tissue is that it's very easy to manipulate. It doesn't fold on itself easily. So you just hold it with a tweezer or tissue forceps and just push it in, and you don't have to worry about folding on itself or having undesirable shape. And it's also very faster to do in your clinic. So this is how we sutured the soft tissue graft. And we also, because I aimed at under correction of the CEJ, I wanted to leave some of this soft tissue graft exposed in a chance that it may keratinize or give me more tissue to work with in the future. And as you can see here, the final tissue, at this phase, the temporary crown is very, very thin because I want to give the tissue enough room to have swelling, desirable swelling. This is how the final suturing looks like. And this is the case, how it looks like after 2 months and ready to take impressions and finalize the case. So you can tell here that we were able to augment the tissue, we were able to solve the problem of tissue deficiency and also have a natural looking crown. And this is here, if we compare before and after, we even gained a little bit of tissue coronally. We know that this tissue will need to be stabilized first before our final impression. And usually this is done with our temporaries. Now it's no more surgical and the patient really appreciate that. And this is how it looks like from the occlusal view, which is very protective from future recession from happening. Now, let's move on up the scale to a more challenging case. Here's a patient. This patient, I have to disclose that, is on a limited budget. So even though we recommended to have crowns and veneers done on the central incisors, the patient by all means refused that. So we went ahead and replaced the missing teeth with lateral incisors with implants. But we suddenly have this problem here, and this will be my point of focus on that case. So I saw the patient after placing the implant with a small tissue problem here. The patient really didn't complain much. However, we know the fate of this thin tissue, that it may shrink over time and or cause the implant threads to be exposed or final abutment to be exposed, and we want to avoid that. So as we examine the crown contours, we remove the crown. This is what we're looking at, very deficient, very weak tissue to start with. I examined the crowns here and I kind of went back a step back, because when we temporize the patient, we put the patient in an over-contoured crown, which is opposite to what we discussed in the previous case. So we really killed ourselves because we put too much pressure on the tissue and there was no room for the tissue to stay. So I went back, I reduced the contours of the crown. I do that on buccal and lingual and also mesial distal. So I want a very, very narrow emergence profile to come up. And patient was sent back with this crown. I understand, I told the patient, this is not a nice looking crown, it's funny looking, but this is one step in order for us to get back to the desired outcome. This is on the picture on the right side is at the time of modification, and the left side, that's after 2 weeks. So we can see that there are some changes in the soft tissue. It's basically getting healthier over time and also much more predictable to work with because there is no or less inclivations of the tissue or scars. So if I compare how the patient showed from the point where I saw him at this phase versus now 2 weeks later and under contouring, we can see that we gained some tissue to cover. On the mesial distal, we have thicker tissue compared to the before. And this is a trick I actually learned from Professor Zucchelli. whenever he's approaching this kind of defects, he's always doing a custom abutment or reducing the contours. Here I was lucky to have a temporary crown, not the final crown, so I was easily able to manipulate the contours. And now if I'm planning to do coronally advanced flap with a connective tissue, I can do that easily because I have much more blood supply coming from the corona. So I go ahead, this is our flap design. This case, I did it when I was a faculty. So if I was to do it again, I would adjust the flap design, but nevertheless, by applying concepts, the concepts will save you, even if you do small problems or small mistakes. So my problem here in this flap, it was too narrow to start with. I would do a slightly wider flap. However, I then de-epithelialized the papillary area to gain blood supply, and also applied the same principles of connective tissue graft that is dense in nature, less fat in it, stabilize that, and also do our coronally advanced flap to cover all the way to the under contoured or under corrected CEJ. So I'm overbuilding in anticipation for the shrinkage. And this is how the case looks like. That's before and that's after. So we can appreciate that with applying proper concepts, it can save us a lot of time and also less stress in our clinic, and also be able to reverse severe defects like this one. And this is how the case looked like from the occlusal view. Okay, moving on to a more challenging case. This again was one of my own cases. Case that was a very straightforward one, failing a central incisor. We placed an immediate implant, and we placed a bone graft, same exact protocol. And later on, we got a little bit of soft tissue deficiency, which we were going to address with a rolling flap. So basically, if we're mostly familiar with that technique where we roll the tissue from the palate to the buccal. So here is the case that I learned the hard way, that sometimes when you push the tissue beyond its elastic capabilities, you get big problems. And my problem here is that I used a very big healing abutment. So when it was time to roll the flap inside to gain buccal tissue, this is what I got. And I was shocked to see that patient. So it was a huge learning experience for me, the hard way, about the power of choices that you do even with your healing abutment. So I told myself, okay, this will remodel over some time. It only got worse over time. And now it's been, at this picture, it was almost 4 months since the uncovery. I was very stressed about it. And I also told the patient it will remodel, but it never happened. So it was time to revisit the concepts that we just discussed and also apply it to even the more severe cases like that. So we went ahead, we removed the healing abutment, we placed a much narrower healing abutment. And the problem that we had was the frenum was too high of an attachment, and also the scar tissue. Let me go back just to highlight that. So the scar tissue that's forming, especially between the central incisor where the frenum pull, it was leaving the tissue very, very thin to do anything with. So what we did here is remove the frenum and place a connective tissue graft underneath the scar tissue. So this scar tissue was elevated with a full thickness flap elevation or tunnel preparation, and then we placed our first connective tissue graft. We thought that was enough. Of course, this is much, much better than what we started. However, we wanted to do more correction, and it's never easy to do these corrections once you have them. So it's always better to prevent it from happening. So this time we wanted to put the implant back to being submerged and let some tissue to grow on top. And then we go ahead after some tissue has formed to tunnel all the way or prepare a tunnel preparation from all the way from the palatal. We use a very dense connective tissue again from the palate and augment all the way on the crest. By that way, when it's time to redo the uncovery, which was our first mistake, we have much more tissue to manipulate this time. And luckily, we had an amazing prosthodontist, Dr. Brombal, to complement our work and also match the stains that happen. Of course, this is far from perfect or good, but from where we started, I think it's acceptable, because once we get complications, we already know that we're at a compromised situation, and we want to communicate with the patient that this is the best we can do for now. And of course, be honest about it with ourselves and the patient. So not a bad result compared to what we started from. So the smart way is to prevent problems like this from happening and to manipulate the tissue the right way. But again, we're here to learn, we're here to advance our techniques, and this is how we fixed that specific case. Now, I'm gonna discuss that case that I showed you at the beginning, which is for me one of the most challenging cases or complications that I had in the aesthetic zone. So let's go back here, what happened, and ask ourselves, what exactly am I looking at? We had a lot of tissue to start with, and then suddenly the patient calls me and telling me I'm not happy with the result, and this is how I see him in the clinic. So let's take a look at the diagnostics once more, okay? Here, what we see here is that, first of all, the temporization, there was a mistake that happened at the temporization where too much pressure was placed on the tissue where it shouldn't have been such over-contoured. So that's the first problem. And the second problem that we have is something happened during our surgical manipulation. There was a delayed healing. I'm not sure what happened exactly. I'm still trying to figure it out. But now we have loss of interproximal bone. Like if you remember what we discussed earlier, interproximal bone will determine how high you can go with your papilla and also how high you can go with your buccal tissue. So I explained to the patient, either we go the ortho extrusion route, which may not be as predictable, or accept a slightly compromised result if we do some crown lengthening on the central incisor, which will also address the aesthetics a little bit, because in general, lateral incisors should be shorter than the central incisors. So we went ahead, we corrected the problem with the temporary. So here's how the contour of the temporary looks like. Again, same principles. We under contour and under correct the CEJ. I draw where I want the CEJ to be so I can finalize the shape of the crown in the lab. And then I start to under contour everything to allow the tissue to grow and prevent the biomaterial or the composite or temporary to occupy the space that should be occupied by the tissue. So I went ahead. This is the manipulation of the temporary. We went ahead, we did a small crown lengthening procedure. We tried with a piezo. So what you're seeing here is the cut after the gingivectomy. And then we did a small osteectomy on the crest with the piezo to re-establish the biological width. And now it was time to, again, same exact thing we did for the past 3 cases, under contour the crown, prepare a tunnel, get a very dense connective tissue that is harvested as a free gingival graft. We remove the epithelium, and then we suture it on the buccal side. And this is how the crown looks like. Of course, it's a very weird looking crown. Again, we know that it's fixing the complication that counts. This is how the under contouring goes all the way. It looks very thin, but that's what we want. And the final seating here, so you can see that there is enough room for the tissue to swell. Now I want to help the tissue to come down, so I used a coronally advancing sling suture with composite. So I maintain this tissue as high as possible and help it with the maturation. I leave these sutures for almost 3 weeks. And then this is the final result after the reline of the temporary. Of course, as I said again, this is far from perfect, but it's acceptable by the patient, and we minimize the number of procedures that we have to do. And I think that's the most rewarding thing to talk about today. This is here before and after from the oblique view. Not very bad, but again, it's not perfect, but we accept that. And here's the occlusal view over here, before and after. So just to conclude things, and here I'm getting ready to finish my presentation. I hope I was very honest with my presentation. It's my learning process, and I hope I was able to share it with you. So my conclusion is, when we look back at the case where we anticipated the problems before happening and correct them before they happen, if we remove the teeth aside, even on the gum level, it looks much nicer when we compare prevention versus correction. And that's basically the conclusion. You want to detect the problems before they happen by understanding the biology correctly. I'm gonna recap what we discussed about these 4 steps. The diagnostic phase, I want to make sure I have good buccal bone and interproximal heights. Otherwise, I want to communicate with the patient with mock-ups or pictures that the crown or the final teeth are not going to look as they look in magazines, for example. In the first implant stage or implant placement, I want to have, at least in my opinion, a conical connection implant that will allow for multiple prosthetic corrections, whether it is an angulated screw channel, multi-unit abutments, or any kind of co-axis entry. It's much easier to uncover these implants and manipulate the tissue with it. At second stage, if I'm planning to temporize the patient and do soft tissue corrections, I want to switch to start from narrow and then build your way up to the desired emergence profile. And then if we follow all of this, this is not a rare case to happen, because we did our job with all the past steps the correct way. And I would like to conclude with, again, predict the problems very early. Also try to understand where the biology is and know the power of your biomaterials. And by that, I mean also understand different implant systems, how they work, and what's the power of their parts. So you're able to manipulate the tissue and prevent big problems from happening beforehand. And I would like to conclude with one of my favorite quotes that I live by today. It's a quote by Nelson Mandela. I'm not sure why it's not appearing on the picture here, but it basically says, don't judge me for my success, judge me by my failures and how I came back from them. And thank you so much, Omid, for this amazing opportunity. I hope it was a learning chance for everyone.
Thank you, Michel. It was actually one of the best lectures on complications, so honest. And really, those cases that you presented are, I think, one of the most common complications that happens in aesthetics around the implants. And me, myself,
yes.
had, many of them. And I believe that it's, I think, most of the dentists' questions. Because as you said, I think one of the most important point is that first of all, we need to have enough good knowledge to know what will happen next. And also, it's very good to know what kind of complications can happen to be able
Exactly.
to manage them at the time of happening. And the most importantly, as you said, to prevent them, but to have some ideas how we can manage them biologically.
That would get the clinician on a different level for sure.
Yeah, exactly. And definitely it needs skills because it's not something easy just to put a graft there and okay, and it works. No, it's not working all the time. So we need to know exactly what are the steps. So one of the things that is really a challenge also for myself, actually, I had a case recently. It was pretty similar, like one of your cases, that you presented putting the connective tissue through the tunnel when the patient had a healing abutment or had a previous improper crown shape, and in a way that you wanted to augment the soft tissue and bring it more coronally and also give it more thickness from the occlusal point of view. So my question is this. Imagine I've placed an implant more to the palate and I have done many soft tissue grafting, so I build the tissue. It's not bad, but when I place my crown, I see that the tissue is more apically comparing to the adjacent teeth. So in that stage, with the healing abutment, not the crown, in that stage, if I want to decide to go for the soft tissue grafting, do you recommend, because I mentioned that the implant is to the palate. So I have tissue thickness here, but even if I have tissue thickness, the dimension of the tissue in an apicocoronal way is not correct. So in that case, do you prefer to put a cover screw and do like a coronally positioned flap and do the soft tissue graft, or you decide again to go with the tunneling approach in the buccal and put another connective tissue graft there?
So very good question. And I also ask myself these questions a lot. When you look back to pictures and you ask yourself what you're gonna do. I think proper diagnostics is the key, okay? I have a rule to live by. Also, it was Dr. Zucchelli who introduced this. How much you can achieve of buccal coverage or buccal advancement depends really on the interproximal tissue height, okay? Even with tunnels, I followed the same rule. So if I were you, if I have a case, I would measure again how much tissue height on the adjacent teeth. If the tissue is high enough, then there is a chance maybe of manipulating the tissue that, like you're saying, maybe adding a connective tissue will help. But if the tissue is not that high really, then there's no point of trying. I would communicate with the patient. I don't want the patient to go on into a surgery unnecessarily. But let's assume that you had enough interproximal height. So either I did both ways, like you mentioned. One case I had the cover screw to be placed back, and then after I augment that, I have a better chance of moving that apical, which is actually more coronal than before. Or maybe in that case, I would like to do a custom healing abutment or temporize the patient with a crown, at least make the patient happy he has a crown. But you have to undercorrect things the way we just explained to give more room for the tissue to grow. If you already have thick tissue, I wouldn't, maybe I would give a chance by just manipulating the emergence profile. Again, healing abutments are very like prefabricated. You don't have control on the shape. So you cannot control really the shape of the emergence. But if you put a customized healing abutment or a temporary crown, then maybe you have better chance of pushing the tissue under the gum the right way so it masks the recession or the deficiency that you have.
I got it. And one more thing, you presented the cases of the lateral incisor that there was a concavity. but there was no fenestration. So the
Yeah,
approach that you went through the vista incision and you insert your graft material under the periosteum, subperiosteum,
exactly.
exactly on the bone. So I think it was
Yeah.
kind of like smart approach by Ernesto Lee, right? It was kind of
Yes,
same procedure.
it is exactly the same. Uh, this procedure, it's funny though. We used to do vista incisions and bone graft uh, before anyone can describe it. Dr. Ernesto has been a mentor of mine and everyone in residency programs in the US. And I think he was the one to have a solid publication on that technique
Yeah.
and also recommend a growth factor, PDGF, to be placed with the bone so you can have better chances of this actually turning to bone.
Yeah.
So, yes, it's exactly the same.
So now my question is this. What if the case has some fenestration in the area? Do you also
Yeah.
go with the same approach or approach going to be different?
It's a very good question. If you were not able to prevent the fenestrations, I would go the same approach, but this time I would go and place a collagen membrane because you don't know if soft tissue was trapped or anything that was trapped inside the flap. And you want really to be very thorough when you clean these after you elevate the tissue away from the bone. I want to place a membrane, collagen membrane, in between the flap and the implant because most likely you tear the periosteum and you want to exclude that tear. Otherwise, you got soft tissue infiltration. But then again, you do the same bone graft and suture, and it's a very simple procedure to do.
Yeah, and my final question, Michel, was about the type of abutment that you presented. It was
Mm-hmm.
in the category you mentioned the conical abutment.
Yeah,
Uh, is it specifically for Nobel or there is a line for such abutments?
it's implant specific. So most implant companies they have more than implant lines, and most of them they have conical connections. So Nobel have the Nobel Active, which is a conical connection. Straumann is a conical connection, and Neodent, for example, is a conical connection. And it's very important to choose the right system for the right case, and that's a whole different topic of
Yeah.
interest as well.
So you prefer to usually go with the because in type of when we want to provisionalize, we can go with like a stay-in abutments or we can go with the tie bases with temporary abutments. So this is kind of things that usually people talk about these days. Like one of my guests going to be Thomas Linkiewicz. So he talks
Nice.
about it these days about the staying abutments and something not to remove all the time, something to be
Yeah,
there and add something on it instead of
exactly.
when a screw.
Yes. I think if your question about tie bases, it's exactly the same. Conical connection, it applies to all sorts of abutments that you have in an implant line. So it's the same for healing abutments, temporary abutments, tie bases. The connection platform is the same; it won't change.
Yeah,
Um, yeah.
great. I think I can have lots of discussions, like
Thank
hours and hours, but I just want to say thank you so much, Michelle.
I really appreciate you having me here.
You put a
I
lot of
hope
energy.
these.
Yeah, go ahead.
And I really appreciate your actually your symposium was kind of inspiring. I would like to, like I told you, I want to come to Iran either way, but specifically to your symposium because I feel like I'm gonna see a lot of honest cases where people share their complications and really how to come back. And it's one of the very few in the world, actually.
I will make it happen. I will make it
Yeah.
for sure. Yeah, when I'm saying something, I'm doing it. So, so we'll be more than happy to have you in Iran, and really
Definitely,
again want to
be a
appreciate
pleasure.
your support and that
It'll
you
be a
accepted this
pleasure.
invitation.
Thank you
You
so much.
shared beautiful, most demanding cases in complication management in aesthetic implant dentistry. Thank you so
Thank
much
you.
again for joining us. Hope to see you soon.
My
Stay
pleasure.
safe.
Thank
Thumbs
you. You
up.
stay safe. All right.
Thanks, buddy.
Thanks.